Good evening. As you know, the purpose of ward round is to uh, check the readiness of the residents as to the day-to-day working in the ward, whether it is pre-operative assessment or post-operative care, to know whether the resident understands the nuances of the ward work. Is he able to identify complications and problems early and act on them? And does he know what are the possible complications? Does he know about does he or she know about the patient's condition? And in terms of pre-operative assessment, what are the things you need to know before the patient is shifted to the OT? So ward round is generally a test of the day-to-day working in the ward. So with that in mind, now we'll start with whatever patients we have in the ward. So who is going to present? Samir.
First case, Samir is going to present, sir.
Samir, you need to start presenting cases. Okay, you start.
Good evening, everyone. We're patient at 312 B now. He came with abdominal distension, and patient was complaining of multiple episodes of loose stool, vomiting, and decreased urine output. He had a comorbidity of past history of hypertension, IST, and post CABG and CKD. Past surgical history of ankle fracture, and the patient is not mobilizing right now, and was referred to us in view of abdominal distension and constipation. On examination, the vitals were stable, and per abdominal finding were like his patient had distension and bowel sounds were sluggish. Per rectal within normal limits, and blood investigation were also within normal limits.
So, what at this stage, Nikita, what are the thoughts going through your mind? Patient who has ischemic heart disease, post ABG, and I don't know the CKD business because his creatinine has always been normal.
Normal, sir. Yes, it was recent onset, it seems, sir. So,
but where is the CKD coming from? Because you need to have a creatinine value higher than normal at some stage. I have never seen a CKD creatinine value high in this patient. Anyway.
And he was not on dialysis also, sir, just medically managed.
Anyway, I don't know whether the CKD is just a facade or was it really there? We don't know. I think unless they have diagnosed based on the GFR and things like that. So what are the possibilities in this patient? Patient has had multiple episodes of diarrhea, abdominal distension, vomiting, and on examination, abdomen is distended. Was it tender, Samir?
Non-tender, sir.
Samir, what if it is tender, man?
Sir, most likely it will be rupture, sir.
What rupture, man? What are you talking about? Rupture of what?
Like peritonitis, or we can suspect peritonitis.
Peritonitis is one. Let us say it's not peritonitis. What else can it be? Huh?
Perforation, sir. Bowel perforation.
That you said no. Perforation, you said perforation peritonitis. Yeah?
Yes, sir.
And what else? Nikita, last Ainath. If patient, you are examining the patient, abdomen is distended, it is tender on palpation. What else do you expect and what are the possibilities?
Sir, it could be diverticulitis, sir. We could suspect like that could also cause distension along with the constipation and tenderness. And sir, ischemia could also be one cause, sir.
Ischemic bowel, correct. That is
Yes,
what
sir.
ischemic bowel or imminent perforation, peritonitis. Does pancreatitis not give you tenderness?
Yes, sir. Pancreatitis as well. Like, sir, then in terms of only tenderness, then depending on the location, sir, like if it is epigastric tenderness, we could suspect pancreatitis. But if it is in the right iliac fossa, we could also suspect appendicitis, sir. But like not with this age group, sir. Like,
That is what my questions will never be addressed in some hypothetical patient. This is about this 80-year-old man.
yes, sir. It won't. So pancreatitis we can
Even with
suspect, sir.
pancreatitis, you can have generalized distension and tenderness, which could be everywhere, maybe more in the epigastric region, associated with garding, rigidity, and things like that. So now, Nikita, what are the
Yes, sir.
things that are going through your mind in this patient particularly? Diarrhea, vomiting, distension, abdomen is distended but not tender.
Yes, sir. Initially, the suspicion would be an obstruction, sir. It's a classical obstruction. And the causes of obstruction we could, yes, sir.
Why,
Sir,
why diarrhea? If you have
it
obstruction,
could be spurious diarrhea distal to the obstruction
what is
zone, sir.
spurious diarrhea?
It's like overflow diarrhea, sir, from distal to the obstruction due to the pressure which has been built up proximal to it. There will be some leakage of fluid post that, sir.
Not just that. Let us ask, we know if there is potential obstruction, when can the patient have diarrhea?
So if it is like partial obstruction, it can have.
Partial obstruction, yes, agreed. Then what else?
If it is because of malignancy, something, if it is spurious diarrhea, because of chronic obstruction, the stools will liquefy because of, and then it will lead to pass some jelly stools, which is called as spurious diarrhea.
But what is the reason for that? Tanya or Nitya?
When the bowel gets blocked with hard stools, some of the liquid component that is present will manage to pass through them. That is called that will cause the diarrhea.
That is one thing. Other what else can it be? If there is stricture or obstruction, and then there is
Associated
Over-
inflammation, sir.
bacterial overgrowth. There will be the stagnation, severe bacterial overgrowth, and that will cause serious diarrhea. Okay, so now you are suspecting obstruction. Nikita, what else?
Yes.
What else would you suspect in this patient?
Because of the CABG status and history, sir, initial thought would go towards, though rare, ischemia of bowel, sir. Could
Not rare. It is
Not
quite
rare.
common.
oh,
So
yes.
ischemic colitis, yes, ischemic colitis is certainly one possibility. And what else?
Can't we suspect paralytic ileus, sir?
Why suddenly paralytic ileus?
Because this patient is sedentary and painless distension.
We can suspect paralytic ileus.
And second thing would be mass, sir. Any malignancy which has, considering his age, there could be a malignancy.
Malignancy, diverticulitis, stricture,
Yes, sir.
ischemic colitis. Can you have Crohn's disease in a patient like him?
Should be complaining pain, right, sir?
Distension is very rare.
No, you can get obstruction. You can get
Secondary to fixed.
you can get toxic megacolon.
Yes.
But Crohn's disease, in India is rare, and at that age, it's usually 60 to 70. The second small, peak that happens at between the 6th and 7th decades. The first one is in the 2nd to 3rd decade, and the small second peak is in the 6th to 7th decade. So 80 years unlikely suddenly patient who has had, if previously has had Crohn's disease, then we can certainly think of it as one of the complications of Crohn's. But if he has not been diagnosed with one, you can't make a diagnosis at 8 years. Okay. Now, I think probably, and he has previously had laparoscopic cholecystectomy, correct?
Additions.
Yeah, I think Samir missed that point, but can you have additions?
Yes.
You can have additions, but laparoscopic surgery additions are much less common compared to open surgery, but it can still happen. So, possibilities, intestinal obstruction, secondary to, at this age, malignancies first, diverticular disease second, ischemic colitis third, postoperative additions fourth. So these are the,
Can we think about a TB abdomen, sir, in this case? Like, can that be kept as a differential, sir?
you can, but what evidence have you got if you think of TB? No, TB can be a differential diagnosis in any situation. But why specifically did you think of TB?
Because it is like a most common
No, but
disease and
on examination, was there anything on examination to point towards tuberculosis? Did you have a doughy abdomen? Did you have
no,
any mass pain? Did you have ascites?
no, sir.
See, you can have various kinds of tuberculous peritonitis. You can have a cocoon formation. You can have
Yes.
this bowel obstruction. I agree with all of that, but is he a diabetic? Is he diabetic?
No,
Nikita?
sir. He is only hypertensive and CKD, sir.
So, if the patient is diabetic, you could potentially because much common in diabetics, tuberculosis is much common in diabetics. You can certainly think of tuberculosis, but there has been no, findings to point towards tuberculosis.
Okay, sir.
Okay.
Yes.
So, how are you going to proceed with investigating this man? Why are you silent? Come on, quick.
Before investigating, we would like to do initial management, sir. Like first NTO status and Ryle's tube and abdominal girth monitoring, sir. Then we go ahead with enema, IV fluids.
Why enema? Don't give enema. You
Okay.
are suspecting obstruction. Why are you going to give him enema? Don't do that. So just, I think I agree with you. Give him oxygen, start IV fluids, and, then he's not in pain, so you don't have to give him painkillers at the moment. Right tube, I agree. Drip and suck, what they call IV fluids, and right tube or nasogastric tube. You have to do investigations. What are the investigations you will do initially?
First and foremost, we would like to do an erect X-ray abdomen, sir, to confirm the diagnosis. If
Abdomen, so if he's got an ankle fracture, how will you get an erect abdomen? It may be not possible. If it is possible, do it. Otherwise, do a supine abdomen with an S1.
yes, sir, that will also.
X-ray. Prop him up and get an erect chest X-ray. Why are you looking at erect chest X-ray?
Sir, to look at the air fluid levels, to confirm obstruction.
Air under the diaphragm.
Yes, under the
diaphragm.
You are looking at air under the diaphragm. You are also looking at, as Nitya said, if it is any tuberculosis, you need to see if there is any evidence of tuberculosis, with probably, consolidation or fibrosis, old, calcific nodules in the lung, things like that, which may point towards it being tuberculosis. Certainly, tuberculosis should be kept in mind, but not so not so high in the list. So look for gas under the diaphragm, look for any pathology in the chest, mediastinal widening, and then you supine abdomen, look for air fluid levels and evidence of obstruction, and also some printing which will indicate what will some printing indicate,
Sir, sorry, sir.
printing, print sign.
Divertically, sir.
No. Tanya, Nitya, usually indicates ischemia of the bowel. Okay, so if there is print sign, then it indicates ischemia of the bowel. Can also look for if there is any air, air in the in between.
Wall.
It looks a bubble and or in the air in the wall. So any of those things you need to look for, not just something that is obvious like multiple air fluid levels, which will be obvious anyway. So look for other things. Always don't look at something that is staring at you, that is obvious. And even if you teach somebody, they will also be able to pick it up. So picking up the obvious, of course, you should do that. But in addition, your eyes should look for other subtle signs which may indicate, for example, sometimes you have hair along the psoas. That shows that there is pre-perforation somewhere. So things like that. You should always look for something which may lead you to the diagnosis. Okay. So chest X-ray, erect chest X-ray. If patient is possible, you can do an erect abdomen. Otherwise, do a supine abdomen, erect chest X-ray. Then bloods. What are the things in blood you are going to do? Praveen, you have been silent. Praveen?
Sir, yes, sir.
Ah.
Sir, routine complete blood picture as
Yeah.
patient is CKD in case of creatinine will be doing.
Ah.
Along with it, as there is suspect of obstruction to the lactate, sir.
Okay.
And
Don't prompt anything. Let him answer. Exams, you will not be there to help him. Yes. Come on. What else?
and
Now tell Nikita.
yes,
Please run out.
Electrolytes, sir.
Electrolyte. Why do you want electrolyte?
Sir, just to make sure that the obstruction is not because of the electrolyte imbalance. And did the obstruction cause an electrolyte imbalance to retrospectively?
See, I expect better answers from you guys. See, what nonsense are you saying? See, you can have hypokalemia, but this is not ideal anyway. But in a patient with renal failure, what is that you are worried about? You suspect this patient may be in renal failure. He has had multiple episodes of diarrhea, vomiting, so you may have what? If it is renal failure, what are you worried about in renal failure? One indication for dialysis.
Hyperkalemia, sir.
hyperkalemia, sir.
Why are you guys, why so much prompting is not necessary. You need to look for hyperkalemia, hyponatremia, and then, because the patient suspected to have acute renal failure or chronic renal failure, so potassium, could be high, or there can be hyponatremia also. So you look at all the electrolyte imbalances. You need to do a blood gas on him. Very important. You didn't mention that. See what the blood gases show. Early sign of either sepsis, ischemia. The blood gases will show metabolic acidosis. As you said, serum lactate you should do. And then, liver function test also. Look at serum, albumin levels. And potentially, if you are entertaining pancreatitis, you should do amylase and lipase also. Can amylase lipase be increased in any other condition other than pancreatitis?
Sir, amylase is elevated even in obstruction and diverticulosis.
So obstruction can also, but the elevation would not be this high, higher than 3 or 4 times the normal, as we see in pancreatitis, but it can be elevated. So amylase lipase should be done. Then all these things. Now you have a baseline of all the blood. What definitive investigation will tell you what's going on.
CT abdomen and pelvis, sir.
Colposcopy.
Contrast enhanced CT.
Yes.
See, the only thing is we need to see what the creatinine levels are. before thinking of giving him IV contrast. But oral contrast, rectal contrast can be given without any problem. Okay, so that it doesn't have any bearing on the renal parameters. IV contrast will have. So we should be careful about IV contrast. If the creatinine is high, don't give him IV contrast. So the contrast NRCT, oral and rectal contrast.
Yes,
So
sir.
what did it show in this patient, Nikita?
So in this patient, oral contrast along with IV contrast, along with rectal contrast was given, sir. Oral contrast did not reach the
Rectum.
rectum, sir. So it showed dilated bowel loops, with small bowel and transverse ascending colon dilatation, bowel dilatations, with the transition point being the splenic flexure, sir. Suspected it to be neoplastic growth, and distal to that there was fecal loading of colon.
They didn't say that neoplastic growth, did they?
They commented it, sir.
Originally, they commented that there is potential neoplastic growth there.
Yes, sir. In first CT, they have commented, sir.
Okay. Right. No.
They were saying there was a wall thickening and all, suspected it to be neoplastic, sir.
Okay. Right. And then?
And then rectal contrast was given, which showed that it has passed beyond the splenic flexure, the transition point, proximally, sir. So it was reported as partial obstruction due to growth at the splenic flexure, sir.
So now, the next investigation?
Colonoscopy was done, sir.
Do you think it is necessary?
No.
Sir?
Since they're mentioning about neoplasm, colonoscopy would be important.
But why?
Sir, but in the stage when the patient is having
Conditions is not required, sir.
dilated bowel loop, can a colonoscopy be indicated because it can potentially lead to a perforation?
That is my question. So you are asking the same question to me. So that's why I asked, do you think colonoscopy is indicated? If
Not
so,
in the, not
right.
Sir, but as they commented it to be a partial obstruction and patient was passing stools after the contrast and all. So in that
Yes, sir.
scenario with like partial obstruction situation, we can go ahead with colonoscopy, sir. Could we?
Also, they just mentioned about the bowel wall thickening, sir. They didn't tell as such a growth or anything.
compulsory neoplasm.
So see, the answer should be like this. See, I just wanted to know how you think it. See, basically, he is a man of 80. He has a lot of comorbidities. So my question is a trick question. However, there are both sides to it. One is that would you like to do anything definitive in somebody of that age and with those comorbidities without proof of what you are dealing with? Are you going to do that?
No.
No.
No, so that is why you need the colonoscopy. So you don't need a full colonoscopy because you know the problem is at the splenic flexure. So you can do a flexible sigmoidoscopy, reach the splenic flexure. Be very careful. See, I always tell you guys, after 75 years of age, unless there is proof, like when you do a rectal examination at the tip of your finger, you feel a growth, or when you are doing an abdominal examination, you feel a mass in the colonic region, or when you are investigating, there is definitive, like this patient, there is a definitive evidence to suggest possibility of a malignancy or some pathology, which you need to know what it is. Only such patients you need to subject them to colonoscopy. The reason being, majority of these people have very small atonic colon. Second is the bowel will be very, very, dilated and loose. So the potential for perforation is quite high, and you will be, passing the entire scope and you'll still be in the sigmoid colon. It has happened to many people. So, because the colon is so dilated and atonic, it will take the entire colonoscope and it is still in the sigmoid or in the descending colon. So there are lots, and then there is also the potential possibility of diverticular disease, which could potentially cause perforation. So you should have a very high threshold to doing the colonoscopy in elderly people. However, when there is definitive evidence of disease, for you to prove the diagnosis before you make a definitive decision about management, you need to have proof. So for that sake, you do a colonoscopy. So in this patient, Nitya, does that answer your question?
Yes,
Hello?
sir. Yes,
Ah.
sir. Yes, sir.
So you have to balance your investigations. You should know what is the question you are asking, what is the answer you are wanting before you make the decision. So here there has been no kind of, if you look at the CT, it's not like a apple core lesion, classical apple core, where you say there is no doubt that this is colon. So that is another thing. When you said, don't you need to do colonoscopy? The answer would be, if, for example, on the CT, there is definite evidence of a apple core lesion, you don't really need to do, colonoscopy. You can go ahead because especially in an elderly man, and you are potentially there is risk of perforation anyway. But there is already obstruction with apple core lesion. So surgery is definitely indicated. So you can then say, I will resect and send the specimen for histologic proof. For chemotherapy, if at all you are contemplating chemotherapy, definitely you need histologic proof. But for surgery, when there is a patient who is obstructed and the CT scan shows the classical lesion with apple core or whatever, napkin ring, such patients you can argue and say you may not need a colonoscopy. However, when the risk of surgery is very high, for you to justify to yourself and to the patient's relatives why you need to operate on them, you may need histologic proof. So such cases you may want to do it, which is why colonoscopy was done, which is justified. Unfortunately, 3 colonoscopies was done and that is not justified. What are you going to gain by doing 3 colonoscopies in the same patient? Because it's not going to matter as far as your diet. Because somehow they thought it is pseudo obstruction. When the CT shows classically that there is a lesion, it is unlikely there is pseudo obstruction. So 3 colonoscopies were definitely not indicated. PET CT again, possibly not indicated. It's been done anyway. So I think it is unfortunately just muddied the water. It has not shown any obvious lesion. It has suggested some very rare. I have never seen a polyp interception in my life, and not in the left colon. Not at splenic flexion. You can see interception in the. See, these are areas that are fixed. So how can you have interception there? Impossible almost. So very, very rare. Unless the colon is not fixed and is very lax. It probably was not in this case, as you will see later. So it made the diagnosis, it gave a wrong impression. Now, you have seen this patient. See, the only thing is he has had one laparoscopic cholecystectomy, which could potentially, cause bowel obstruction. I'm not denying that. But generally, laparoscopic surgery does not cause so much of addition. So on that caveat, I think you had no business waiting on this patient for so long without operating. I think 3-4 days have lapsed before we have been referred again. Is that correct, Gita?
Yes, sir. Yes, sir.
So I think, just a minute. Good evening, Professor Malik. Sir, I am in an online class. Can I call you later, sir? Okay, thank you. Thanks. Sorry, that was Professor Malik from yesterday's symposium. He wanted to talk to me. I just took the call out of courtesy. Sorry. So 3-4 days have elapsed. I would ask Nitya and Sanya, what is the dictum on intestinal obstruction? Nitya
Sir,
first.
the sun should not set on the same day. If
Sun will always set on the same day, man.
I mean, during the episode of obstruction,
You are right. The words you used were not correct. That's all. See, don't let sunset on an intestinal obstruction. See, sun will rise on the same day and set on the same day. So, what it means is, don't let sunset means don't wait for the next day. So, especially if it is small bowel obstruction. So, large bowel obstruction also has similar connotation. The only exception to the rule is if it is a post-operative status. If the patient has a virgin abdomen, which this patient probably has because laparoscopic cholecystectomy, you can consider still it is a virgin abdomen. So, don't let sunset on a bowel obstruction, be it small or large. So, 3-4 days have elapsed. So, I think Dr. Munireddy was asked to see the patient because I think initially Dr. Subhash was seeing the patient and then he asked Dr. Munireddy to see. And Munireddy sir asked me also to see the patient. Who was there with me when we saw this patient? Anybody?
I was there with you, sir.
So what did I say immediately?
Sir, he needs to be operated. So we have to plan as soon as possible was the thing, sir.
So basically, I think all of you need to do the same thing. Whenever you see somebody like this, see whether the anesthetist will agree for your surgery, whether the patient will agree for your surgery is also important. But more important is what is your decision. So you have to be clear in what you say. See, the thing is, when patients like this is there, we all know the risk. We all know what are the comorbidities. However, we also know that if this patient has to have any chance of recovering, he has to be operated. So that you make a decision. You say operation is necessary, but with the caveats of all these risks that are there. So you have to talk to the relatives. I think the counseling of this patient depends on how your approach is. If you are an aggressive surgeon who wants to operate, who has to operate because this patient needs surgery, you will pitch it in such a way that you have to explain to them that the risk, the benefits outweigh the risk. Though we do understand there are risks. And same with the anesthetist. So you tell the anesthetist, you can dissociate this patient whichever way you want. You want to give them spinal or epidural. You can't give general anesthesia, but you have to somehow give an anesthesia for this patient because we have to operate on it. But knowing our anesthetic department, I don't think they will refuse this. Fellow was fairly stable. His counts were normal. His creatinine was normal. His urine output was good. He was not on inotropic support. He was not on ventilator support. He was not needing high dose of oxygen. And he was not tachypneic, tachycardic, nothing. So, what is the reason to say no to this patient? I don't think there was anything. Anyway, planned surgery for next day. Dr. Munireddy also came and saw and agreed with me, and we planned surgery next. So, now, Sanya, will go to you and Nitya. What incision will you plan, or what approach will you plan for this patient? I'll start with you, Sanya. Nitya, you also will.
Usually for a patient with obstruction, we'll go with the midline laparotomy only, sir. Depending on the site of obstruction where it is, either upper midline or lower midline, extending beyond the umbilicus.
Right.
But in this patient, since it was depending on whatever is found inside, then we can change our incision or put an additional incision if required, sir.
Correct.
If the approach is difficult.
Nitya, would you consider laparoscopy?
This patient, because he's already has comorbidities, it will lead to cardiorespiratory compromise, sir. Plus, there is it's an emergency surgery, so open would be a better approach, sir. Like we don't know the pathology, so laparoscopy would be
See,
not a.
your answer is correct, but the reasoning is partially correct,
There's
partially wrong. See,
there's no space for pneumo, sir.
see, the thing is, in patients with cardiopulmonary, sort of compromise, we do keep the insufflation pressures at a lower level. So,
Okay.
I agree, venous return can be compromised. So, hence, instead of 12 to 14, keep it at 8 to 10. But the main problem, what is the main problem, Tanya?
So there's no space to create
Correct.
pneumoperitoneum.
See, first of all, access into the abdomen is difficult. There is a very high chance you may perforate something because
Okay.
there is no space. Second, even if you are exceptionally talented, good, and lucky, you may be able to access the abdomen. But then what can you do? Everything, there is no space. Even if you put a lot of air, again, that, will also have the same thing that Nitya said of potential cardiopulmonary compromise because of, your insufflation pressure being high. There will be decreased IVC return, and so the blood pressure will drop down, all those things. And they'll find it difficult to, ventilate the patient because your diaphragm is, kind of stiff because of the pressure. But beyond all those things, if you can't see anything, you can't do anything. Even if you get into the abdomen, you can't put other force and manipulate or whatever because bowel is there everywhere. So, first of all, you may not be able to find the pathology. Second, even if you find the pathology, you may not be able to do anything. So, I think laparoscopy is probably only major, I wouldn't say absolute contraindication, only major contraindication for laparoscopy is when the patient is obstructed. Especially when there is significant distension of abdomen, it is practically not impossible, but very difficult to do anything. The only counterpoint to that is if, for example, there is just a band, you would feel bad if you just have to do a major laparotomy just to, divide the band. So in those situations, if at all you can manage to enter the abdomen, identify the points of obstruction, if there is a band, just cut it. You would have avoided a major laparotomy. But those instances are rare. So I would say that laparotomy is the right thing in this patient. The pathology, what they had suggested was in the splenic flexure. Of course, you can reach splenic flexure through a midline laparotomy, but this man was huge and very, very dilated, and the access to spleen was extremely difficult. So hence, we had to add a left subcostal incision to a midline laparotomy. Okay. Tanya, you were there in the surgery. Correct?
Yes, sir. Yes, I was there.
So describe what happened.
Sir, first when we like after we started with the midline laparotomy, after which we noticed that there was distension of the bowel, small bowel also, and large bowel up to the splenic flexure. It was distended. So it was and the splenic flexure was there was a mass formation at the splenic flexure. Therefore, it was difficult to mobilize the splenic flexure at the first when we enter through the midline laparotomy. So we had to make a transverse incision along the left lumbar region to reach the splenic flexure. And once we reached the splenic flexure, we saw that there was a hard mass-like thing near the splenic flexure with a small bowel attached to it and omentum also attached to the same place. So we had to dissect that, and then we did resection of the splenic flexure along with the 5 centimeter margin. And then we did a end-to-side anastomosis of transverse colon with the descending colon. And then we gave him a diversion ileostomy.
Right. Now, Nikita, see, this patient had a very tight stricture at the splenic flexure. The transverse colon up to the cecum was very dilated. Why didn't he perforate?
So because as it was a partial obstruction, sir.
Not partial. Vinod, why didn't he perforate, man?
Sir, I see valve was and the back pressure is going into the small bowels.
Ileocecal valve was incompetent.
Incompetent.
Good fortune. Otherwise, this patient would have perforated and probably died.
Yes, sir.
So, because the ileocecal valve was incompetent, the small bowel was also dilated. So the obstruction was packed up into the small bowel. So hence, he was lucky that he didn't perforate. Okay. So now, we know we did a end-to-side anastomosis. What was the rationale? Why couldn't we do a end-to-end anastomosis?
Sir, proximal bowel will be dilated because of chronic obstruction.
Correct.
So there is discrepancy between when anastomosing the distal segment with the proximal segment. So end to side is a better option.
Correct. That is one good reason. Nitya, can you think of another reason why we did an end to side rather than an end to end?
Sir, the vascularity of the anastomosis is in the end to side, the vascularity is more, so that the uptake is better in.
That's another reason. So we did an end to side, and then should you always do a diversion ileostomy? Tanya, Nitya.
No, sir. For this chronic
Sir,
obstruction,
For
Sir, I didn't your question, sir.
You know, unless you have become Sanya or Nitya, just let them answer the question.
sorry, sir.
Okay. Nitya first and then Sanya.
Sir, since we have done, it was a case of a chronic obstruction and the bowel wall will have some edema, sir. So the anastomosis have to be taken up. So we need to prevent contamination or any kind of activity in that anastomosis area. So it's better to do a diversion so that it gets an adequate time for the healing process and also the edema to settle down, sir.
Okay, that is one good reason. Sanya, anything else?
No, sir, the same thing. Because there was pathology at that site, the healing would be, and because of the gross distension of the proximal bowel which was present, if we die, and colocolic anastomosis is usually not very like as good as the small bowel anastomosis that we do. So, noting all this, and the patient.
Most of them. See, the first thing is colonic anastomosis, especially the left colon, the blood supply is suspect. As you know, the critical point of Sudex, all those things come in that area. What is critical point of Sudex, man? You know, now answer the question.
Yes, sir. It is splenic flexure point. So the vascularity will be less in that area.
Because of the
This superior mesenteric and inferior mesenteric anastomosis at that point.
there is a kind of lacuna in that, hiatus, if you like, between the two anastomosis. So there is critical area where the blood supply is compromised. So that is one reason. So the lesion was in that area, edematous, dilated bowel. So, and then emergency surgery, suspect vascularity, and one more
Nutrition can we tell, sir?
Huh?
Nutrition.
This is what I was expecting. You didn't say that. So this patient, one is he's got lot of comorbidities. Potentially, the bogey of chronic renal failure comes. So renal failure is also one of the causes for wound healing, defective wound healing. Correct?
Yes.
So renal
Yes.
failure, patient has ischemic heart disease, so left colon maybe, and nutrition. Patient is being vomiting, diarrhea, probably not eating well, abdomen is distended for at least 7 to 10 days before that he is not probably eating well. So this is why I told you LFT should be done. If the patient's albumin is less than 3, you have no business just doing an anastomy. You have to protect it. Otherwise, you can certainly think of it will leak. See, the other reason is, which you have all, I think you have done well enumerating the reasons why a backup or a diversion ileostomy has to be done. But another thing you have to also think of is, see, this is a patient who has post-operatively lot of comorbidities, ischemic heart disease, and renal failure, hypertension, old age, obese man, and immobile. So we have to do something that is virtually foolproof. Because this man will not give us a second chance. If there is a leak in this anastomosis, you can almost be certain he will not give you a second chance to take him back to the OT and clean him. So, for all these reasons, you have to give them a ileostomy. What are the potential problems of ileostomy immediately post-operative?
Sir, electrolyte imbalance, sir.
Come on, man. Immediately, what electrolyte imbalance will you have? I'm talking about immediately. Nikita, let us ask this one. Ravi.
Sir, skin excoriation, sir.
All those things will take time, man. Please understand.
Stenosis. Non-functioning of the
Which part of immediate don't you understand? Okay, Nitya and then Sanya.
Sir, it can retract. The ileostomy can be.
Yeah,
Can.
Ileostomy can retract. Correct. That's one. Why do you put a transparent, thing on the top? See, you can put a completely opaque bag, you put a transparent thing. Or if you have put an opaque thing, you take out the bag and see. What do you see?
Sir, the content.
Ischemia, any signs of ischemia or
the stoma can go dead. See, if, for example, if you have not created the stoma properly, if the stoma is coming through a very tight, refine, and you have not created, adequate space for it, or other thing is, if you have taken a stitch which has gone through, the thing, it can also bleed, of course, but mainly if the orifice is not adequate, the stoma can become ischemic. So, ischemia and retraction, these are the two immediate complications after stoma. Whatever other things you suggested, if ileostomy output is high, you can have electrolyte imbalance. If the spout of the stoma is not adequate, you can have excoriation because the content can be very, potentially not toxic, but irritant to the skin and cause irritation and, excoriation. And then there are all other complications like the, parastomal hernia, prolapse of the stoma, all of these things. But the two immediate complications are retraction and ischemia and, dead stoma. Other thing is, sometimes it has happened to even senior consultants. That is why, Sanya, what did we do? We kept on saying what is proximal, what is distal, no?
Yes, sir, yes.
So what happens?
Then we can, while taking out the loop of ileum, it can get rotated. So the distal can come up and proximal goes down. So we'll end up pouting the distal and making the proximal flat.
See, that is another thing. See, other thing that can happen is, when you are bringing out the stoma, you have to ensure that there is no rotation. If there is, you can cause obstruction. That is the third immediate complication. I forgot to mention that. It can cause retraction, ischemia, obstruction. Because if you have rotated the stoma, it can cause obstruction. And I have seen my own consultant do this. See, sometimes we do what is called as a functional end colostomy, where you open out the proximal end and close the distal end, but bring out both of them so that the proximal end is active and the distal end is closed. So you can do the opposite. You can close the proximal end and bring out the distal end so the stoma doesn't work. So that will happen. I've seen it at least 2 or 3 times. You think, some of these things, a senior consultant cannot do. But sometimes if you are tired and things, if you are not paying attention, that is why whenever I tell you guys, I will never let any one of you do the stoma if I am gone. Not because I don't trust you, it is because it is bad enough for us to give a stoma. Because would any one of you take a stoma? I don't think any one of us will accept stoma. But if stoma is inevitable, at least do a very good job of it. It should not cause complications to patient, because you don't want something that is unwanted to become a complicated one. That will make patient even more, angry, frustrated, and depressed also. So that is why doing performing a stoma is a very, very important time. And what is also true is majority of the times we do the stoma after a major operation. Potentially we are all tired. If so, take a break. Go and have a cup of coffee or tea, whatever you like, and then do it. So that you make sure that you do the stoma correctly. So that is it. So I have seen 2 or 3 times the wrong end being stapled off and other end being brought up. So that is another complication that can happen. So you have to be very careful about it. Now you have done this operation. We know what are the problems that you anticipate in this patient.
Sir, delayed functioning of bowel, sir,
Okay.
and nutrition.
No, all those things are made, but what are the problems immediately that you anticipate? What did we do? Were you, who else was there? Nikita, were you there?
Yes, sir.
What is the immediate thing that you worry about with this patient? What did we do, and what are the repercussions of that? If you remember, in the end, what did we do, and what are the repercussions?
We did put a drain, sir.
You put a drain, but before putting a drain, what did we do?
Bowel wash was given, sir. And
What?
bowel walk was done.
Huh?
Decompression also has been done, sir, before closure.
Yeah, all those things have done. They are not dangerous. What did we do that was potentially dangerous? Or what? I didn't do it, but somebody else did it. But anyway, somebody did it. Sanya?
Sir, I don't recall.
There was clinic trauma, right?
Yes, sir, yes.
So there was a splenic trauma, there was capsular tear of the spleen, and there was bleeding. So what did we do? We cauterized it, put cell, we packed that area, and waited for about 20 to 30 minutes before we closed the abdomen. Correct?
Yes, sir. Yes, sir.
See, that is the right thing to have done. Still, it could bleed later. So one of the things that you have to worry about is post-operative bleeding in this patient. So we have put a drain there. You can have significant amount of bleeding from the drain. So that is one complication. What other complications do you expect? Tanya?
Giving away of the anastomosis that we had done.
No, that is later, ma. It won't. I think you and I have done a decent job. We are not that terrible surgeons that within 4
Yes,
hours.
that distal loop seemed to be a little hazy to me, so I was not sure about that.
No. I don't think that is the. See, even that is the case, it will not happen. The anastomotic breakdown or dehiscence will not happen on the day 0, day 1, day 2.
Yes, sir, yes, too.
So major technical flaw, day 2, day 3, otherwise day 5 to day 10 is the anastomotic leak time. Correct?
Yes, sir, yes.
So now we are asking, you have operated on this patient, what are the immediate problems that you expect?
Apart from the bleeding and retraction of the stoma or ischemia of the stoma,
Yeah,
Uh,
we have already, this one,
mentioned those, yes, sir.
I mentioned that. What else can happen?
One more could be paralytic ileus only, sir, because of excessive handling of bowel.
Again, that is a later complication. See, you not expect, if the bowel doesn't work on day 1, day 2, you won't say it's paralytic ileus. You'll say it's just normal post-operative period, right?
Yes, sir. If
What other things that you can think of? See, he may develop a chest infection quickly.
chest, yes, sir. Yes,
So
chest
he cannot
complication, yes,
come out
sir.
of the ventilator. You would have usually such patients you would have done elective ventilation. If we take him out of the ventilator next day, he may not come out. So that is one. He may have a myocardial infarction or an acute coronary syndrome. Can he not?
Yes, sir. Yes, sir. Yes.
And other thing is, remember, this patient has an ankle fracture and has been immobile. He can have a pulmonary embolism. Because oncology, old age, obesity, immobility, cancer, long operations, all the potential, reasons are there for pulmonary embolism. Correct?
Yes, sir.
So see, you have to think logically. Now, when we ask for complications, it is not just local complications. You have to think of all the other complications also. So, local we have already enlisted, bleeding and stoma complications. And second is, other general complications like he can have it because, he's gone through a major surgery, potential little bit of blood loss. He can have an acute coronary syndrome or a myocardial infarction. He can have, because he's had ischemic heart disease and previous CABG, he can have cardiac arrhythmia. And he can also have respiratory infection, pulmonary embolism. And other thing is, if there is hypotension, he can go into acute tubular necrosis. So, onset of renal acute kidney injury. All these things can happen at, in the first 24 to 48, 72 hours. Subsequently, all of these things that you enlisted from the anastomotic leak. How will you diagnose an anastomotic leak in this man, Tanya? Because you already got a stoma.
Yes, sir. Mainly the drain that we have kept should help us identify the leak. Or if patient is in
may or may not help. Drain, if it shows bilious or bowel content, yes, it is
yes, sir.
the anastomotic leak. Yeah.
So this patient will be in sepsis with features of peritonitis.
So you will have other things before the drain shows bowel content. So the abdominal distension, then the stenting of the diaphragm, tachycardia, tachypnea, inability to come out of the ventilator, urine compartment syndrome like picture, urine output dropping, blood gases show metabolic acidosis, counts go up. In this patient, counts did go up, but all other parameters were normal. So we didn't worry too much about counts going up. But all other parameters like the urine output was good, he didn't have tachycardia, didn't have tachycardia, came out of the ventilator, day 0, and we didn't need inotropic support, the urine output was good, abdominal depth was manageable, and the stoma started working on day 3 or something. So all of the things were favorable. But anastomotic leak diagnosis is difficult. See, all of you have to understand that assessment for postoperative abdomen, even for a very experienced surgeon, is very difficult. Even investigations may not actually, point in the right direction. See, many times what happens is bedside ultrasound, unless it shows a large collection, it is of not much use because most of the time abdomen is distended, so bowel loops will come in the way of a proper ultrasound exam. So that is one. And many times the patient is unwell, ventilated, so it will be difficult for you to shift him to do a CT. So clinical assessment becomes paramount, but again, that is also very difficult. So you have to, if you cannot make a decision at one go, repeated examination of the patient, repeated assessment of the parameters may help you in making the decision. Otherwise, it is very tough. So don't get disheartened if you have missed it. It is It is very difficult to assess a post-operative abdomen. So you have to have a lot of experience and then also repeated examination and look at other parameters, surrogate markers, as we say, which will help us to make the decision correct. So, Vinod, when will you start nutritional support for this patient?
Sir, immediately I'll start TPN, sir.
Why do you want to start TPN immediately? Why can't you use the gut?
Sir, this patient is already from many days is not not having any nutrition because of obstruction. Only we are giving IV fluids and this.
Correct. So I'll still use the gut.
Hello, sir.
I will still use the gut. He's not had nutrition, but I will use the gut to give him nutrition.
Yes.
No, you're
But-
not. Your answer is correct. Try and justify it.
Sir, bowel to initiate the movements, it takes time, sir, for the gut
Huh?
movement.
What?
Bowel movements, for the gut to function, it will take time,
I'm
sir.
not interested in
So-
bowel movement. I'm interested in absorption.
Absorption.
What happens to absorption? The bowel is dilated, edematous, and probably in obstructed bowel, the absorption is questionable. So you have to start TPN, and then as and when the patient signs of the bowel function return, then you can start. Now, even giving a test feed of 10-20 ml of sugar water or plain water is acceptable. Why should you do that, Ravi? See,
Sir.
even if the patient is obstructed, you still start on day one. You start giving, if the patient has an nasogastric tube, you start giving some fluid through that. Why do you want to do that?
To initiate the bowel movements, sir. We
Can
can
you
initiate the peristalsis, sir.
Can you think by giving something it will initiate the bowel movement? There is already about 8 liters of fluid going through the bowel. So how is 10 ml or 20 ml going to help you? Nikita?
Sir, just to keep the mucosa patent, like
Nikita, you are mumbling something. Tanya?
So just to make sure if the patient is going to tolerate.
See, it is correct. It is test. So that is why it's called test feed. But more than that, what you have to understand is the feed that you give will improve the mucosal blood flow. So that is very important. So anything, whatever you infuse will improve the mucosal blood flow. So if the mucosal blood flow is improved, then the mucosal integrity is maintained. The mucosal integrity is maintained, the bacterial translocation that happens if the mucosal junctions are disrupted or stretched will be less. So that is why you start feeding because gut is the largest contributor to immunology, and also translocation of bacteria is a definite, source of endogenous infection. So bacterial translocation is a proven identity. It is not a theory, it is not a concept, it is a proven thing. We have actually done experiments to show that. So, mucosal blood flow is very vital, and as Sanya said, it's a test. So, if the patient is tolerating it, you can increase the amount and gradually. It is right to start the TPN because the patient has not been eating and drinking for a long time, and the absorption from the gut in an obstructed bowel is suspect. So, if you are right to doing that, and then it will take about 4 to 5 days of crossover before you can establish an entirely optimal enteral nutrition. So, in that time, you don't want to waste time and starve the patient. So, you start TPN, and gradually, as the gut absorption increases, you start tapering the TPN, and then, see, the ideal thing to do would be to give TPN overnight, and during the day, if the patient is awake and alert, we can allow them to orally take it. See, because if the TPN is going, there will be no appetite for the patient, because everything is, the sugar levels are normal, everything is taken care of. So the patient won't feel hungry. As such, he's in ICU, he's had a bad operation, he's been not well for some time, so appetite is not good anyway. In addition, the TPN is also ensuring that he doesn't have an appetite. So what you do is you give the TPN from maybe 6, 7 o'clock or 8 o'clock at night till morning, and during the day, the patient is, awake and alert, mobilize the patient and give them orally. And as the oral intake increases, or if nasogastric, we give them nasogastric. In some patients, we do a feeding jejunostomy. We feed them through the jejunostomy. And then, as and when the enteral feeding takes over completely, then you can taper the TPN and stop. Again, TPN causes massive shifts, ionic shifts in the body. It is a hygroscopic hyperosmolar solution. So do not stop TPN abruptly. You have to stop it, taper it, and stop it. That's it. I think it is time. Still, there are a lot of things to discuss, even with this patient, and anyway, post-operative care. I think we have covered a lot of things. Any questions, any clarifications?
No, sir.
So let us start from the youngest, Samir.
Sir,
Was
yes, sir.
you find the class useful?
Yes, sir, of course.
No, you can say no if you didn't. I won't take any offense.
No, no,
Huh?
that's
No.
very,
Huh?
that's very useful, sir.
Ainar? Ainar? Hello?
She went to the case, sir. There was a call from the wards.
Okay. Nikita, Praveen.
Sir, I have one doubt, sir. Initially, in this patient was suspected of partial obstruction, sir. And patient was passing stools. So in this case, at how much time we might wait for conservative management, sir, before taking step into surgical?
See, the thing is, we have established it very well, especially in the benefit of retrospective scope or retrospective analysis, that it was the virtually complete obstruction. So the diarrhea what he had was spurious there. So I don't think there is any need to wait in this case. Absolutely not.
Okay, sir.
Okay, right.
Yes, sir.
And in such a patient with abdominal distension, constipation, like with partial obstruction, in whom can we consider giving enema, sir?
See,
Enema or bowel,
no.
orally when we give Pegleg and on for the to help the patient pass stools.
Don't even go there, because you can cause bowel, perforation if you give bowel preparation in such patients. So that is a no-no. But enema only if you feel there is significant rectal loading. If the rectum and is loaded, then you give him an enema and even manual evacuation. You can do that, but see, I don't think that is the answer to an obstruction. CT will give you the reason for the obstruction and you deal accordingly.
Okay, sir.
Sir, why in this patient there is no pain, sir? Generally in obstructions it should be painful.
You tell me. Why was there no pain in this patient? That is because, again, the ileocecal valve was incompetent. So the small bowel was also massively dilated and he vomited. So he was venting the obstruction from time to time. But still he should have had pain. It is a bit, but patients they don't read textbooks, so sometimes it cannot be there. This pain threshold might have been high.
Sir, he had rise tube from the early onset only, so that would also be relieving his obstruction.
That is very. Okay, so Nikita,
Yes, sir. This was the one of the recent most speculated case, sir, while
Ah.
handling, and the discussion retrospectively is very informative, sir. Actually.
see, I've tried to imagine the situation without knowing all the, the diagnosis and everything, so that we discussed it as if it was a case
Yes.
which we didn't know, and we managed it as we went along. So I think, that is what we should do, so that we understand, all the things that we did right, and some of the things we may not have done it right. Sanya and Nitya, what was your?
Yes, sir. Very useful discussion, sir.
See, this ward round should be always like this. Here we spent an entire hour discussing this patient, but sometimes you may not have so many issues to discuss. So what you do is have 3-4 cases and discuss each of them, so that you will have a good, working knowledge of how to handle intraoperative, postoperative problems. That's all. Okay. So every facet of our teaching has to address certain, aspect of the training. That is intraoperative problem solving, or, post-operative identification of complications, early identification of complications, anticipation of complications and preventing them. That is usually on table. And, that is what, for example, we did with the ileostomy, and that is what we did with the, the stopping of the splenic bleeding. So we don't want to, wake up, be woken up in the middle of the night with a problem. So anticipation and prevention of complications, and then complications which are inevitable to every surgeon. When it happens, early identification, so that you handle them, sooner than later. Don't bury your head in sand and think, I will not have any complications. All of us will have. You just have to understand what the problem is and deal with it early. So that is all, I think that is the facet of wardrobe. So wardrobes are, designed to, train our minds in how we manage patients pre-operatively, intraoperatively, and postoperatively. Okay, good night.
Good night.
Good night, sir.
Good enough.